And the city of Calgary is also home to the Métis Nation of Alberta Region 3. So I'm Jill Norris. I'm our scientific writer here in the Nursing Research Office, and I'm here on behalf of our Associate Dean Research, Karen Benzies, who I'm assuming is going to be touching down in Australia at any moment. She's actually there for 3 conferences, if you can believe it. I don't know how you can combine one trip into 3 conferences. It's pretty awesome. So as part of our new research strategic plan, our nursing research office has been hosting international experts to help our faculty build both methodological and operational capacity across substantive areas in nursing. So some of you may have already taken our project management course, so that's just an example of one of the initiatives that we've offered. So today we're kicking off our fall offering with a talk on implementation science that we are thrilled to host and have been planning for a long time. So hailing from Michigan, Laura Damschroder is a research investigator with the Veterans Affairs Ann Arbor Center for Clinical Management Research and a project principal investigator with PROVE, Personalizing Options Through Veteran Engagement, Quality Enhancement Research Initiative, or QUERY. I'm sure that term is familiar to some of you. Ms. Damschroder is an international leader in advancing the science of implementation and is the lead author of the Consolidated Framework for Implementation Research, one of the most widely cited papers in implementation science. And so just yesterday, I checked to see how many citations there were, and there's nearly 3,000 citations of that initial framework, which is amazing. And I know that I've used CFIR in some of our work. She has been a visiting scholar at many institutions around the world, has led national workshops, and actively mentors young researchers. She's also a recognized leader in evaluating and implementing lifestyle change and other prevention programs to prevent chronic disease and improving health and well-being. So Laura's talk will take us to 1 p.m., so we're going to do this for about an hour, and then we have a 30-minute Q&A session. I know some of you are going to have to run off right at 1 o'clock because you have other commitments, but for the rest of you, please stick around, and please help me welcome Laura to our faculty. Thanks.
Thank you, and thank you for showing up today. I hear this is the first week of school. School starts tomorrow. A lot of very young people walking around campus and walking sleepily into breakfast this morning. Got to join them in their dining hall this morning, which was a lot of fun. We will have like Jill said, a half hour of, I hope, to have some dialogue. I have many slides that I may or may not get through all of them. I have been accused of speaking in a language that is sometimes hard to access because I've been in the field of implementation science for a while, and I'm like a fish swimming in this water, and I don't realize that I'm necessarily using terms that people may not understand, but and also concepts. I have a lot packed into this slide set. And there's a lot of devil in the details about how exactly can we accomplish and meet these, kind of goals and this roadmap that I'm laying out this afternoon. So it looks like this is being recorded. Is it going to be posted somewhere or not necessarily? But anyway, you're welcome to my slides. I'm happy to share them. Just maybe contact Jill. I'll make sure that she has a copy of them. But all of this information is freely available. I'll also be making reference to a technical assistance website that we have available as well, and a lot of the information that I'm conveying today is on that website or available through that website as well. So what I want to do this morning, or this afternoon, is talk about one particular framework that implementation, the science of implementation, offers as a way of systematically assessing or understanding the complex contexts in which we attempt to implement all too often hugely complex innovations. I think, I don't know how many of you in the room try to implement, pills, for example. I don't know, in my book, that's fairly easy to do. Just, give them a blue pill instead of a white pill. I'm sure I'm oversimplifying that because there are issues even with that. What I tend to implement are more complex behavior change programs. So trying to, in smoking cessation and especially in lifestyle behavior change in terms of increasing levels of physical activity, changing diet, healthier diet as a way of preventing diabetes and many other chronic conditions, including cancers. So that's kind of the realm of a lot of the work that I have done. I also collaborate on a lot of other topics as well, especially within mental health, and those practices, treatments are never simple. And especially when they meet kind of the complexities and the dynamics of organizations, and anytime you have more than or two or more people in a room, things get complicated. If everyone just did things my way, it would be a very simple world, and we'd be in a lot of trouble, I know. But I also want to, so I'm going to talk about the CFIR as a framework, kind of an illustrative framework. There are many, many, many frameworks and models that have been published in the sphere of implementation science. The principles that I talk about today related to applying a framework like the CFIR can apply to any framework. So I don't at all want to imply that the CFIR is the world's answer to doing implementation science, but rather it is a way of kind of making sense of the world. It's one lens into trying to make sense of the world. But there are many other lenses as well that also are bringing much value to the table. So I want to, and then more broadly, kind of situate frameworks like this into our goal, really, as scientists, to build theory so that, and then also practical recommendations. So my goals for today are just to talk about the overarching goals for implementation research, present a few case studies using the CFIR in particular, how we can use that information that we gain, our knowledge, our articulation of context into tailoring implementation strategies for higher success or likelihood of successful implementation, and then kind of revisiting an overall roadmap for moving the science of implementation forward. So there are really dual goals for implementation science. One is just the science of it, and in this piece of goal, we need to be collaborative. We want to build a knowledge base in a systematic way. And I think that in the science of implementation in particular, it is a multidisciplinary science. Sometimes I refer to it as a MUT science because it draws off of organizational theory. I just learned about institutional ethnography, sociology, organizational change theory, health psychology, industrial psychology. So we're kind of sitting on the shoulders of much older scientific disciplines. And because we're tackling and embracing complex contexts as well as innovations in those complex contexts, we need to be collaborative because we have a lot of variables that we're attempting to understand. It all too often feels like we're drinking from a fire hose in terms of trying to digest and make sense of it all. And then we have the praxis or the practical aspect of this science. And I think that this science in particular, we're really called on, and I see myself as having a foot in, or attempting to have a foot in both the kind of theory building facet of the science as well as in the real world, in the struggling primary care practice in rural settings versus those that are in inner city, low resource settings. And then identifying in terms of practical recommendations and in identifying effective strategies and how to tailor strategies for successful implementation. So the power of theory. It provides an organizing framework for conducting research studies. So for those of you who are researchers, how many of you have written a proposal for funding to get funding, or probably will in the future? So there, more than half, I would say, in the room. You have to have, there's always a section of the proposal, just very practical, where you have to have a theoretical framework that kind of underlines or underlies and guides the work that you're proposing. You need to be able to articulate why the innovation or the intervention or the work that you're doing, what the impact, what kind of impact will it have, and why? What are those mechanisms of change? So we need theory in order to do that. And using an organizing framework gives us a common language for articulating that. We also want to build the scientific knowledge base, like I said earlier. We need to understand the context around which we're attempting to implement new practices and understand the mechanisms of action and generalizing. Theory also provides terms and definitions, or a language, and all in all, it creates an efficient way to systematically build these collective knowledge bases. So theory can be kind of ephemeral, abstract, ivory tower, but it's also very practical. I mean, all of us are using theories every day. If I set the alarm clock, I think I'll get up on time. That's a theory, really at its foundation. So when we talk about developing and testing innovations or interventions, for example, the Diabetes Prevention Program is a lifestyle change program that is targeted to people who are at particularly high risk for diabetes, and a program to improve lifestyle behaviors to prevent full manifestation of diabetes. And we might have an underlying theoretical model, a bunch of boxes and arrows, basically, that encapsulate why we think this program will work. And the goal of innovation, or this kind of basic science, is to improve the health and well-being of patients, ultimately, because why else would we be doing this? But with these innovations, we need to be able to identify and understand what are the active ingredients. So what are the components of each of these multi-component interventions that really are contributing toward improving outcomes for patients? We also, and in doing so, we also need to understand how to adapt programs differently within different settings. The goal of a typical randomized control trial of an intervention is to establish internal validity. So meaning that we want to control as many things in the trial as possible so that we can establish that if I'm doing this program, it is resulting, or it is the reason that I am getting this impact on outcomes, hopefully positive impact. So we need to establish that causal pathway, or that connection. But all too often, RCTs alone are not sufficient. They do not provide the information that we implementation scientists need, or implementers, practitioners, need to be able to successfully implement an evidence-based intervention that came out positive in a control trial. Because we don't have information about what are the key components. Do I have to implement all 10? How do I adapt those for my particular setting? And so, like I said, the randomized control trials, or RCTs, tend to control or ignore context. Context is messy and undesirable, basically, in RCTs. An example of some work that we've done with lifestyle interventions, we did a randomized control trial of a weight loss intervention that had multiple behavior change components, including diet and physical activity, and coaching around that with patients or with participants. And this was an effectiveness randomized control trial. And we found that we actually created a way of assessing how the coaches were working with their patients. And of course, there's variability across patients and across coaches, and being able to kind of measure how that coaching is being delivered to patients. We found that the higher fidelity, or the closer the coaches actually stuck to the intended way of coaching, the more participants lost weight, the more weight they lost. We then took that information and in a much more practical demonstration of a very similar lifestyle change program, specifically the diabetes prevention program that I referred to earlier, we created a more practical way of assessing fidelity, and we got confirmation by patients that these particular components of coaching were important to their success, further establishing the specific kind of active ingredients for coaching that seem to contribute toward weight loss. And it's this kind of information that we need coming out of randomized control trials, rather than just what we typically get in published articles are, the DPP worked, or this weight loss trial, the intervention, it worked. But we don't have a good understanding of why. Okay, so we also need an underlying kind of theory for implementing these complex programs. And together, they contribute toward patient outcomes, or impact on patients, positive impact on patients. So if we have an intervention that in a randomized control trial was effective, if we don't implement it well in other settings, then we can't really expect to get those positive outcomes. So it's both the implementation and an effective program that contribute to positive outcomes. And in implementation science, our goal in implementation science within this context is to understand barriers and facilitators and to explain why a particular program worked. So there may be factors, not just the components of the intervention itself, but also factors within the setting within which it's being delivered and implemented and delivered that also contribute toward successful outcomes. And our goal within implementation science then is to establish external validity. We don't want to ignore effectiveness of the actual program, but we need to pay attention to external validity, meaning we need to understand context so that we can give guidance for other organizations into how best to implement the program so that their patients get the full benefit. And in doing so, we need to embrace and understand context in all of its wicked complexity, which greatly complicates our work, but also makes it very interesting. So use of theory and implementation. I'm going to be walking through kind of a roadmap for where theory kind of comes into play through this process of implementing a program in a medical center, a primary care clinic, a school, a community, whatever, across different contexts, depending on what the innovation is. And so the first place that we can apply theory is to guide our assessment of context. What is context? How do we articulate all of these kind of interacting and dynamic factors that may influence my ability to implement a program? So I'm going to talk about an evaluation of a telephone lifestyle coaching program, or TLC. This also is a lifestyle change program. It was delivered by telephone coaching via telephone coaching. So this is not an in-person program. The hope was, or a goal for doing telephone coaching was to reach patients in more rural settings or who were unable to travel in for inpatient programs for weight loss or for behavior change. There were 6 different topics that this program covered, and they received up to 10 calls over 6 months. There was a strong evidence base for doing telephone coaching. Over 9,000 veterans patients within the U.S. were referred to this program over a 19-month period. 57% of those patients who were referred, so not everyone, actually enrolled in the program. Once they were enrolled, most of them completed the program. This is a graph that is showing a kind of a deep dive that we did on 11 of the 20, actually this is showing all 25 of the pilot sites that were testing this program. And you can see that there's a cluster of sites at the top on the right-hand side who were very successful. The higher, the steeper the slope of the lines, the more successful the programs were, or the medical centers were at referring patients. So the more patients they referred. And yet there were some medical centers down at the bottom of the graph, at those lines on the lower right, that really were not successful in referring patients. It seems like a very simple thing to do. All they had to do was refer patients they thought would benefit from telephone coaching. And yet we've got this huge variation, 7 times difference between the highest and the lowest sites in this particular study. So one of the things when we look at effectiveness of implementation, how do we know that we're successful? We need to identify, explicitly identify, I don't know if there's a pointer, maybe not. We need to explicitly identify outcomes. How do we know that we're successful? In our case, we had a measure of penetration, which was that, and we measured that in terms of the number of candidate patients that we thought would benefit from this program, and the ratio of the number of patients who actually were referred to the TLC program. So the higher that ratio was, the more effective implementation was of this process. We have I referred to earlier to a technical assistance website for people who are using the CFIR framework. It can be found at cfirguide.org, and this is just a screenshot of a page where we refer to an article by Anola Proctor and colleagues that explicitly identify and describe potential implementation outcomes. So in your own work, this really is a seminal, important paper to kind of operationalize what your outcomes or what your indicators of implementation are. So for us, our main question was, what are the barriers and facilitators to medical centers being able to implement TLC? And we did this by assessed or identified and assessed context across these 11 sites by interviewing people at each one of those sites who were responsible or somewhat involved or influencing the implementation process for this program. There were 11 sites, like I said. We conducted a total of 103 interviews, so it was a fairly large-scale evaluation. All of the words on here are just basically saying we did a mixed method study. We drew on both qualitative data from interviews and also quantitative data to assess outcomes, and also to select sites, because we wanted to select sites that had high or were likely to have high variation in implementation experience. So that's one thing in implementation science. We love variation because we can learn a lot from sites who are successful and not successful in going forward. And of course, we use the CFIR to guide our assessment of context. So in terms of assessing context, we want to be able to understand who needs to do what differently to integrate a new program into current clinical process or pathways. And we also want to understand which barriers and facilitators need to be addressed. So what are the key factors that seem to really contribute towards success, or if they're absent or kind of manifesting negatively within a facility, an organization, which ones of those are really going to be either showstoppers or really kind of reduce effectiveness of implementation efforts. So again, the CFIR, I'll just do a quick introduction of it. It is Of course, the technical assistance website has the link to the original 2009 paper that describes the CFIR. We also have all of the content from that paper and additional files, plus more, available through the cfirguide.org website, where we list, there are 39 constructs and subconstructs, or let's just say different factors that we think can influence implementation. And what this framework does is that it takes each one of those factors and defines it and attempts to operationalize it in a way that you can use in your own work. So we didn't want to have definitions that were too abstract, but so they're specific enough to be able to apply them in your own work in many different settings. So we have this kind of crazy figure that is in one of the additional files. And the reason, we don't have boxes and arrows because we don't have theories about how these factors all relate together. They may relate differently depending on context. So what this framework provides is more of kind of a building blocks, resource or source of 39 different factors and related factors to consider. And the interactions we have them organized across 5 different domains. And the domains, the boundaries between them are kind of fuzzy. They can be defined and should be defined differently depending on your particular scenario and where implementation is happening and at what level implementation is happening. And I won't get into details about that, but those are really important in your own work to kind of conceptualize where these domains fall within your own work or how you're defining them. So the first domain are characteristics of the intervention itself. For example, the more complex an intervention is, the more difficult it's going to be to implement. So complexity is one of the factors. Another factor that may influence implementation is evidence strength and quality. What are people's perceived or perceptions of how effective this program might be for their patients? So even though I can show you maybe 59 articles that all point toward this being an effective program, if I think that my patients are different in some key way, and I don't think the program is going to work with my patients, that's the important information to capture. So we as scientists can say, well, there's a strong evidence base for this, but people at the local level need to believe that there is that the intervention will work with their patients as well. In this case, I've got examples of quotes that we have heard from people in doing interviews and asking about these factors, and there's a whole process and approach for doing that. But this person said, I was impressed with the evidence, and I know from our own patients they've been successful with a similar program. So this is someone who had a positive perception of the evidence for TLC. And I can tell you the evidence-based, as far as I'm concerned, was exactly the same across all 11 of these sites. But not everyone agreed with this or made statements like this. Within the domain of intervention characteristics is important also, you know how earlier I was talking about understanding what the active ingredients are for multi-component interventions. So which are the core components that are absolutely essential to implement in order to get positive impact with my patients. And then there's what we call the adaptable periphery. And these are components that can be changed or altered or modified to fit your particular context. And it's important to understand which ones can be modified versus the components that cannot be modified. So, for example, one quote is, when we talk about disease prevention and health promotion, the health coaching just fits right in, and it's such a compliment to it. So this is an example of someone talking about high compatibility between the new program and other already existing programs. So what is the degree to which the program aligns? And partly, they made kind of smart adaptations to this program so that it fit with their current clinical processes. And what this diagram shows is, moving from the left to the right, the organization here, these lines, are changing as well as the intervention itself, so that they kind of fit together like puzzle pieces, which is kind of a simplified metaphor. But all right, so the second domain is the outer setting. There are often factors that are out of our control, like let's say I'm working within a medical center. There are incentives, there are payment regulations or policies that are set by the, nationally or by province, that I have no control over, and that really can affect my ability to implement a new program. So I'll just leave it at that. Within the VA, we have system-wide performance measures or quality indicators that that medical centers need to meet. And so in this case, someone said, it helps us to meet performance measures that nationally we need to meet. And so at this particular site, this particular person could see how using the TLC and referring their patients to TLC, that helped them improve their performance in terms of engaging more patients, obese patients, in weight loss. Then the next domain is the inner setting. And the inner setting has the longest list of factors and is kind of the most fleshed out, and it's very kind of complex and dynamic. What goes on within organizations? What are the nature and quality, for example, of networks and communications between professionals across organizational boundaries? Some medical centers have very fluid communications, and those types of settings may be more receptive to new practices. But others might be very hierarchical, and it's really hard to coordinate and communicate with people who are in different departments. And that would be a very different experience implementing a program that might require input from people across different units. In this case, an example quote is related to the degree to which key leaders within the organization, are engaged or supporting the implementation. In this case, this is someone who had a negative perception of the engagement of their leadership because they didn't really think it was worth the time or energy to treat obesity using lifestyle change. So this is an example of where leaders were not engaged, and the extent, and so we want to know what is the extent to which that may decrement or hit on negatively our implementation efforts in that particular facility. The next domain are understanding the individuals, or the attitudes, the beliefs, the confidence of the individuals who are involved in implementation, including also the individuals who will be using or actually doing the referrals of patients to the program in our particular case. And so an example here is, I've heard one physician say, it doesn't work, they regain weight anyway. So what this is showing is that in some contexts, physicians, again, kind of like their leaders, really don't think that lifestyle change or doing behavior change among their patients is going to make a positive impact for their patients. So this would be a case where it may be rather difficult to get a lot of referrals to patients if we're relying on these physicians to do those referrals for telephone coaching. The last domain is this crazy set of arrows down at the bottom. And what we're trying to convey here is the dynamism of implementation. All too often it's going backwards. We've got multiple concurrent efforts going on at the same time. What we do want to see is that generally we're moving forward and in getting programs implemented. You saw in that graph that I showed you that it took a while to ramp up the number of patients that were being referred. And that ramp-up process is really kind of encapsulated with this messy set of arrows at the bottom. So this last domain we refer to as process. So really the process of implementation. There are 4 kind of main constructs or factors: the importance of planning, the importance of execution, the importance of reflecting and evaluating and taking time to do that, to adjust our implementation efforts so that we're kind of fixing and modifying things along the way. And then the last major construct is engaging key stakeholders, including patients, including these physicians who don't believe in the program. And one quote here is, "I didn't even know that was available to my patients." So this was from a physician. And obviously, this physician isn't going to be referring his or her patients to TLC if they don't even know about the program. So that kind of speaks to lack of engagement of key constituency, including physicians. So we do have an interview guide. We have an approach and again, this can be an approach used with any framework. There are many other published frameworks as well. We do have on the cfirguide.org website an interview guide tool that will actually walk you through interviewing or eliciting information for key constructs. Generally speaking, we often don't have the luxury to ask people about all 39 of the factors. But there are approaches that can be used up front to identify maybe the top 10 or 12 factors to focus your efforts on. But still always asking open-ended questions so that you can understand the implementation experience and the story of implementation as you go, or how it's likely to unfold. But you may have kind of high priority factors that you know from experience or through theory or through informants that have worked with with your facility or your organizations that will help you narrow down. So with this interview guide tool, you can select, for example, a factor called networks and communications that I mentioned earlier, and you can check off questions that you might want to include in a master interview guide. And we produce formatted questions with probes, suggested probes, that can then be cut and pasted into an interview guide. So for those of you writing proposals, this is a great place to start. You can change the wording to fit your particular needs in terms of tense, in terms of language. And reviewers are usually quite happy to see a draft interview guide. And then what we do is, and again, I'm not going to go into detail, but I will make a plug for a workshop that we have tomorrow being led by Caitlin Reardon in the back of the room. She's from Ann Arbor along with me, or Michigan, Traverse City actually, but Michigan also. And she will be conducting a workshop tomorrow and going into a lot more detail about how to elicit information through interviews, how to take that qualitative data and then kind of quantify for each factor how it's manifesting within that particular organization. Is it a positive influence or likely to be a positive influence on implementation, or is it likely to be a negative influence or a barrier, potential barrier to implementation? So we went through this process in evaluating barriers and in our kind of journey to identify barriers and facilitators of referring patients to this TLC program. And I just want to, so for this factor called compatibility, this refers to how the perception of how compatible referring patients to this new program is with existing clinical processes. So someone from a site that really had a negative perception, like this isn't going to fit for, in our particular setting, someone said our nurses are specifically forbidden to write orders Everything that gets written has to be written by a physician. And what this does is it creates a bottleneck, because nurses sometimes are much more likely to refer patients because they're the ones who are talking with patients before the physician encounter. But if they can't put the referrals into the system, then that's a major kind of showstopper for getting lots of referrals to TLC to benefit patients. In another site that had a very positive perception of compatibility of this new program, this is someone who said this really helps the patient to have ownership for their process and their living, and it definitely blends in nicely with the health coaching that they were already doing. So they didn't see this as a competitor, but rather they saw this as aligning and strengthening the health coaching that they were already doing. So that's a positive rating that we would put on that particular, for that particular organization. So what we did with all this qualitative data and quantifying this qualitative data, it really gives us a picture numerically then for the more positivist, reductionistic side of the science. We're able to create a matrix that for each of the CFIR, each of the factors that are identified by the CFIR framework, we're able to identify, so those are CFIR factors, or factors that might influence implementation, listed in the first column there. And then the facilities, the 11 facilities or the medical centers are listed across the top. And they go from the lowest, the site with the lowest number of referrals on the left, to the site with the highest number of referrals on the right. And you can see the one on the right had 7 times more referrals than the lowest referral site. And then that's what that is showing. And then for each of the factors, we have a scale going from -2 that shows a very strong manifesting barrier potentially, versus others that like a +1, it goes all the way up to +2. So a +1 would be a facilitator, but it's a kind of a weak facilitator. And we have, guidelines for how to assign these ratings, all the way up to a strong facilitator. So we indicate that for each of the factors. And then because we had 11 sites, which is still a small number, but it's fairly high for qualitative work, we actually did Pearson correlations. For each factor independently, what is the correlation of those ratings with the number of referrals, patient referrals? And we had 7 factors actually that had significant correlations with outcomes or referrals. And so these 7 factors are the ones that are very important then to act on or to intervene on with implementation strategies. So this is an example of compatibility, which I was talking about before. Sites with the lowest number of referrals on the left had lower ratings of compatibility compared to sites on the right that had higher positive manifestations or perceptions of compatibility. And the correlation was 0.55, which is quite high, more than 0.5, so it's a large correlation, strong correlation. And so compatibility is definitely one of the factors that we need to look at in implementing this program in other facilities. So we have this big long matrix. You're not meant to see all the numbers, but rather the red arrows, and there are 7 of them. So out of all of these factors and all of these ratings, we're able to focus down on 7 different factors. These are the 7, actually 6 of them, not sure why I'm missing one. And then we just a very short, pithy description of what it actually looks like, how it manifests when it's a negative barrier versus when it's a positive facilitator. So really understanding that. And then in this particular project, we were working with our partners, and we developed an online toolkit that, using this information and kind of focusing on those factors, referred to materials and resources to help walk people through implementing this program in their medical center, within their clinic. One thing I just want to make a shout out to, there are, for those of you planning implementation projects, there are the STARI guidelines published by Pennock et al. That actually provide if you go to the Equator Network site that has all of the reporting guidelines, like the consort reporting guidelines, this will be on that site, these guidelines for implementation studies. So then the next question, we're identifying who needs to do what differently. We're identifying barriers and facilitators to implementation. Our next step is, okay, so now we've narrowed down to those 7 factors. How do we identify strategies, implementation strategies or approaches for this particular program within these types of medical centers? We have, I collaborated with a group led by Tom Waltz and Byron Powell, who published a series of, there's a protocol paper in implementation science. There is a refined list of 73 implementation strategies that have some level of evidence supporting their effectiveness. And what this is meant to do is to bring, again, in one place, to compile a list of approaches that were found to be successful, at least in some settings, for implementing programs, in particular mental health behavioral programs. And then a third paper actually clustered these 73 strategies into groups, into 9 different groups. So an example is, all right, this is a messy, you'll find this in one of the papers, but it's basically a concept mapping that shows 9 different clusters of strategies, a total of 73 strategies. And for example, one of the clusters is called Provide Interactive Assistance. And it includes very broad strategies like facilitation. So this is where, I as a facilitator I know how to implement a program, and I might travel all over the country and work with different medical centers who are implementing this program. And I kind of help hold their hands and take a very kind of holistic, intensive approach to help people actually implement the program. But it's a very broad strategy, not... so anyway, I want to point that out as one cluster of strategies. Another cluster of strategies is called, strategies that are related to supporting clinicians in implementing a new program. And it includes things like create new clinical teams, which is getting a lot more specific. So some of the strategies are relatively specific. So then how do I select a strategy from that whole list of 73? And I'm just going to skip through very quickly to talk about a study that we did to elicit input from so-called implementation experts about, for each of the CFIR factors, if this is a barrier, which 7 strategies are most likely to address that particular barrier. So I'm just drawing a bunch of lines saying that, for any one of these factors, which strategies are most likely to address that particular barrier. If you put these 2 frameworks together, there are 2,847 different combinations. And actually, one of my colleagues said, there are a lot more permutations of that, but this is just a very simplistic arithmetic multiplication. So what we attempted to do was to narrow it down for you, that if you know you have this factor in play, can we narrow down to a list of strategies smaller than 73? So I'm just going to kind of walk through, what if groups are not doing any feedback about their implementation efforts? It's a construct or a factor that we call reflecting and evaluating. And we found again and again that doing this and doing it well and regularly is really key for successful implementation. So how do we address that? We had, I'm just going to say, a total of 169 respondents. They were international and as well as inside and outside of the VA, so it wasn't just U.S. and it wasn't just Veterans Affairs, our own system within the U.S. And we gave them the list of 73 strategies, and we said for this particular barrier that they're not doing any reflecting and evaluating, what are the strategies that are the 7 most likely to address that as a barrier? And so we asked them to kind of drag and drop into a box. And then we asked them to do this for as many strategies as they had energy for. And each respondent did this exercise for an average of 6 barriers, okay? So for the reflecting and evaluating, when teams are not doing that, what are strategies that we can use to get teams to do that? Well, the top most often endorsed strategies were to develop and implement tools for quality monitoring and to audit and provide feedback. Now, these 2 strategies are not necessarily easy to execute or pull off, and they in themselves can be complex, but at least it narrows you in on where to focus efforts to get teams to reflect and evaluate based on the input of these 169 implementation experts. Or actually, for each strategy, we had between 20 and 25 people who were recommending these strategies for each of the individual barriers. Some strategies, I just want to point out, can help us overcome more than one barrier. So these are 2 factors on the left that both can be helped or overcome by doing audit and providing feedback implementation strategy. So this is a diagram that just shows for this particular barrier that there were 2 strategies that had a majority, meaning more than 50% of our respondents, endorsed that or selected those 2 strategies to address this particular barrier. But we had 8 additional strategies where at least 20% of the respondents also endorsed. So it's not a cut and dried list of strategies for each of the barriers. And many of the barriers did not have any level 1 recommendations, meaning that there was no single strategy that was endorsed by a majority of respondents. So there's not a lot of consensus about which strategies to use, even when we're narrowing it down to a specific barrier. So that sounds kind of depressing, but it does at least shorten the list. And you can see on average there were about 10 or so strategies, better than 73, for each of the barriers that had at least a level 2 recommendation. And the reasons, the rationale that our implementation experts gave for choosing the strategies they chose were very practical. That they needed to be relevant, that they wanted it needed to have an opportunity, a high likelihood of improvement, and it needed to be feasible were the top 3 reasons, which is good, very practical. On our website, the CFIRguide.org website, we do have a link to a tool that we created. It's basically a spreadsheet, an Excel with a bunch of macros in it, embedded in it, where you can go down all of the barriers. And when you identify, like with our TLC program, we identified 7 constructs, and you can select those 7, and then, in this case, those 7. And for reflecting and evaluating, we got the 2 level 1 most strongly endorsed strategies, and then we got an additional 8 level 2 recommendations. So this helps to kind of narrow the possibilities for addressing contextual barriers or potential contextual barriers. And when we put this all together for all 7 barriers, you can see the greens and the yellows and pick out the strategies. But again, there are strategies that can address more than one barrier at a time. So that's another way of thinking about as you're tailoring and selecting strategies. One of the reasons for the lack of consensus, we were hoping for tighter consensus on these recommendations, but one of the reasons we think that there's not as tight consensus as we were hoping is that people are coming to the table with different assumptions about the exact way that a particular strategy will change something in the organization. So for a strategy, a widely defined strategy like audit and provide feedback, which is where you're providing data basically about performance back to clinicians, there are a lot of different ways that you can do that. And who do you give that information to? So the people who are answering this question may have had very different assumptions about how that particular strategy was working and who to involve. And so it's really important to break down each of the strategies to identify the mechanisms of change and to operationalize it very specifically, who's involved, exactly what's happening, the mode of delivery, and all of that for each of the strategies. Okay, so now we're kind of closing the loop. And at this point, I've walked you through a very kind of elaborate process for assessing context, tailoring or selecting your strategies based on your knowledge of context to develop that tailored implementation strategy. And then the next step, of course, is to execute that strategy and to monitor it along the way and make adjustments as needed. And then to evaluate the effectiveness, which means that you have to have identified and be collecting information about key outcomes from your implementation efforts. And this is just kind of a high-level conceptual model to help think about different domains of outcomes. And this is from Enola Proctor's paper that I was mentioning earlier. And then closing this larger loop, we need to assess the fit or the usefulness of using the framework, whatever theories and frameworks you used, and evaluating and reflecting on that in the discussions of your papers or in additional files in some way, communicating your experience of using the actual framework itself. And there aren't very many papers that actually have done that in the published literature, but it's very important for us as scientists so that we can continue to improve and refine our frameworks and our theories. So for example, Ilat and colleagues did a nice kind of reflection on the CFIR and had recommendations for expanding the framework and for operationalizing some of the constructs. So in the end, in terms of implementation science, using frameworks, again, give you, and I hope I've demonstrated, how it can give you common terminology and constructs or language for, in this case, assessing context and using qualitative and quantitative data along the way. And understanding how to adapt and active ingredients of the actual intervention that's being implemented, and selecting strategies. And so from a scientific perspective, we get very, we want to be systematic and consistent in how we're doing this and building the evidence base. And because our unit of analysis is a medical center, not individual people, we don't have the luxury of large sample sizes, of large study sites. And so using a common language and a common way of assessing allows me to share my findings, my experience with yours. And we can cross-pollinate and compare and build on one another's experiences over time. And then packaging for the real world, we want to create guidance for successful implementation. So how do we create an easy-to-use self-assessment of context And then from that information to select appropriate implementation strategies and creating maybe repositories to help guide practitioners through their implementation efforts. And that's it. So really, we want to understand what works where and why so that we can create these recommendations for practitioners. Thank you. So I guess any questions, comments, experiences, based on your own work?
I'll be selfish and ask the first question.
Yay, somebody has to break the ice.
Yeah, so I'm really intrigued about your CFIR trial and the high fidelity coaching. And so you were telling us about how you had patients confirm those key ingredients of the high fidelity coaching. I think in healthcare, in my mind, I think that we often ask the practitioners, but getting to the patient level about what worked for you is really interesting. And I wonder if you could tell us a little bit more about that.
Yeah, so we actually have a paper published that goes into great detail about the actual components or domains of coaching from the Aspire trial. And then we simplified that. We didn't use the entire checklist or in the DPP implementation, so a separate study. And we also elicited input from patients. But it was not an exact one-to-one crosswalk. So for example, if I'm trying, it's been a while since I've looked at exactly the items and the domains, but I think, there was something about, building rapport, trust, and then in terms of the fidelity of coaching and the quality of coaching. And then we had a question to patients about their level of trust in what their coach was sharing. We actually added a domain about the extent to which the coaches were engaging patients as a group, rather than just didactically delivering a bunch of information. And then we also asked patients how they felt about their group. I don't remember the exact words, but trying to get at that group cohesion idea. So those are just two examples. But we have the measure that we used in the DPP study, the second study. That's in the paper that was published in Implementation Science. Yeah. Go ahead. I think contact Jill. Do you have an email, or do you want to say?
Yes.
Does everyone know you?
Access, but it's jmnorris@ucalgary.ca.
Yes.
Nicole, maybe we can send out an update around that with our registered list. Okay.
Any other questions? Go ahead.
So as we know, we have multiple causes for any health problem. So how would you advise to prioritize the factors to address or take up for intervening on?
So I think what you're asking is if you've got a particular domain, patient conditions or goal, I guess, with patients, how do you select the interventions and then the components within those interventions? Is that what you're asking?
For example, like in childhood obesity, this is a topic. We can start from the pre-pregnancy. We have some factors like smoking, pre-pregnancy, gestational, weight gain or physical activity, and then mental health also has, and then early weaning, and even going up to the adolescence. So there are a lot of factors. How in that complex scenario, where would you suggest to intervene?
Where do you start?
Yeah, this is because this we are focusing on school interventions, but not what was a child started with, what was the home environment, what was the time or environment when he or she was being developed as a fetus. So this is, in this scenario, again, this becomes a complex intervention. So we cannot go for all factors, so then how would you prioritize?
Yeah, so that's a very challenging question, and I don't think that we as scientists have really served the practitioner world very well in terms of how to walk through that decision process. So there is a whole cadre of interventions that you could choose from a menu of interventions that have been shown to be effective in clinical trials, and that intervene on, early, prenatal, or midway, or perinatal, or post-delivery. All of those may be important points of intervention. And so I think that, having kind of a strategic roadmap type approach to identifying where the biggest need is and breaking it down into kind of a staged, holistic process, you certainly cannot hope to do it all in one chunk, but rather take a kind of a staged or incremental approach. I don't know personally I know of lots of repositories of effective programs that are online. Canada, I think it's out of McMaster University, has a huge scientific evidence base. You can go, what is it? Cochrane synthesis group also has an enormous repository with all kinds of information about effectiveness of interventions. And you can go in and search by topic, And so those might be places to start in terms of matching interventions with where you're identifying are the biggest need for patients on this lifespan trajectory. And then, in terms of what the priorities are, I think that really that's kind of more fundamental research. I mean, if there's epidemiological data about, kind of the impact or where the greatest positive impact can be done, probably the earlier you intervene in the pregnancy span, the better, right? I mean, I think that clinically that's probably been shown. And so that would be kind of a natural place to start. And then where I pick up in my work is you've made that decision. And now you're trying to get, community health centers, general practitioners, wherever these mothers are interacting with the system and trying to get these interventions implemented in a reliable way so that those mothers get the benefit of those programs. And the choice, I guess, just to complicate it a little bit more, the choice of those programs may vary by context. For example, there may be interventions that have been shown to work in community settings, and in some areas, it might be more effective to focus on community-based interventions. But then in other settings or other communities, it might be better to focus on a general practitioner, setting to interact with those moms, or OB-GYN, or, So I don't know if that helps, but basically, I think it's important to be strategic about it. Yeah. Yes. Hi.
I ask a question in that we're thinking a lot about interventions that need to scale. So we have lots of funding available for these projects that look at not just making a change that we know is effective at one site, but we're looking to test it there, sort of figure out preliminarily, how does it work? What are
Right.
some of the main key factors of the intervention? How can we refine it to move it to scale and to be more effective and more cost effective in doing so? And so part of my experience using CFIR is actually coming into the design of the grant, using a CFIR type thinking to get to where we need to be in the granting process. Then we get an award and we go in preemptively into some of the sites, and they tell us about some of the key characteristics and contextual factors, barriers, and facilitators. And then we hedge our bets with our interview guide. And we go to those sites and do it systematically throughout all of the people that we need to talk to. The trouble that I'm having comes in with when we do that across, like, let's say 2 or 3, and we get kind of a really refined sense for what would happen if. We sometimes, the healthcare system's still moving, right? We're still doing things. And so I have this idea of barriers and facilitators, but the system's still moving ahead. They're still implementing. So they told me about this thing. I'm hedging based on what they've told me. They're still moving and they're evolving the way that their interaction with the intervention and their contextual factors are actually dynamic. And so now I'm moving into kind of the process evaluation piece where I'm saying, it's okay, keep going, but I'm still gonna poke at each of those providers to see, like, what are they telling me now? And so it's almost, I wanna say, like, you know, we're supposed to do stepwise scale, but I'm having difficulty moving CFIR along with me in a systematic way that makes sense to publish. I'm using it very pragmatically and like salting the earth with
Yeah,
it, but
yeah.
I need answers as I go to be able to understand what I need to ask the next set and how to refine the intervention to get to scale.
So you all probably can't hear Kelly's question, but I think in a nutshell, it is that I've been talking about barriers and facilitators as if they're a static entity. They're not. And so you do all this pre-work to figure out what the appropriate barriers and facilitators are, especially when we think, like in the case of our study, it's taken the VA, it's been 5 years since they did this pilot. And they haven't been able to get they're finally just getting contracts in place to actually deliver it to more medical centers. Do I really think those same 7 barriers are going to be or factors are still going to be the ones in play when the system has changed in the meantime? And in Kelly's case, they may be actually rolling out TLC, and I'm waiting for funding on my grant project. But the system has rolled forward, and so the train has left the station. We have that a lot, actually, in the VA in our setting. Absolutely. And so I think that the key is that, well, first of all, we take a kind of a rapid analysis approach to feed back information so that they can make adjustments as they go. To tell you the truth, the CFIR language is not necessarily helpful to use, like with our partners and with the systems who are actually rolling out these programs. And so rather to keep the language, keep that feedback in like the native language. And feedback, those are your rapid results. Sometimes the CFIR can help you articulate, think about the factors that you should look for along the way, so can help inform that. Some of the constructs translate quite nicely into communications with our health systems partners. Others are more abstract and need to be interpreted and are also very specific in terms of how they manifest. I don't worry about that too much, but when it comes time to publish, keeping as much of that data, those artifacts, those reports, those field notes. You may or may not have opportunities to do formal interviews to find out along the way, but identify as many points of naturally collected data as you possibly can. And all of that can be analyzed post project. And when we publish then, it's more of a reflection, a retrospective, rather than, you may have been using it prospectively to help inform, but then when it comes time to publish, you're kind of retrospectively explaining what happened.
When it's almost moving a process, like something that's structured as a process evaluation, or even a preemptive, we're taking a theory-driven approach, it actually pushes it so far along the process that we're saying now we're actually evaluating pre-scale. That's all we're doing. They're moving as they're moving, and we're actually narratively attending them as they move to pre-scale.
And by pre-scale, you mean that they've already implemented it in a handful of sites, they're doing it, but they haven't gotten it to the entire system, or in your case, the entire province.
Yeah, they
And
talk
that's,
to each other.
yeah.
They're modifying the practice environment as they're hearing the new research come.
Yeah.
And so by the time we get preemptive process, they're already we're
Yeah.
actually post-evaluating them pre-scale anyway.
Well, and part of the challenge, so the sites that you may have identified in your proposal as participating in this may already have implemented by the time you get funding.
Yeah.
So what do you do? Well, I don't know that there's any real good answer to that, but I know in our setting, there was one project that I'm working on now, or that I have now, is we did not pre-funding identify the specific sites, but rather we did a poll to find out the level of interest, or to confirm that there was a high level of interest of participating. And so in our proposal, we said 90% of the people on this national phone call, it was out of 100 people, said that yes, they'd be interested in participating, indicating a high level of interest. And when the time comes and we get the funding, then we'll, randomly select or go through whatever systematic process to identify the sites. So that's another way of doing that, is to, or doing a hybrid approach of studying the sites that, as they, retrospectively, but then adding additional sites beyond what's already been done. But, in terms of how you handle that will vary greatly by scenario, by what your relationship is with your partner, with your funders, and with what your goals are as well. It's not, yeah. So, I think the key for me is trying to find a way to not name sites ahead of time when I know that my partner is steamrolling forward implementing. I also try to make it very clear to reviewers, if you don't fund this now, this round, we're going to miss the boat, and we're going to miss this really important opportunity. And I say that again and again in my grants. Sometimes I wonder, how much that, kind of helped the score and the funding.
To fidelity, right?
Yeah.
Because we don't know how and why.
Yeah.
And then we decide we're going to now do it to 40 sites or 60 sites across the province without really having that idea of fidelity and quality and what actually happened and how people adapted and what they're doing.
Right.
They may be actually taking core components of the intervention and bending them
Right.
and not even using
Bending them in ways that may really,
breaking it.
right.
So then we're actually scaling garbage or
Yeah.
scaling something that's less than
Scaling
quality.
garbage, yeah.
Yeah, right. And
Yeah.
it's a concern because the fidelity is actually lost in
Yeah.
that transfer from the testing
Yeah.
process to now let's do it to everybody.
I think the trick is, so you don't keep yourself up at night about, it is to really define for yourself what you have control over, what you don't have control over, and making the best of the dynamic mess, I guess, of the real world. Yeah. Doing RCTs is so much easier.
Yeah.
It's easy to design, easy to conduct, easy to write. But for some reason, I didn't choose that path myself. I don't know. You have a question?
I just wanted to comment, I'm on the other side of this one, the community health and food service organization, and we're in the middle of an implementation project. And this has been really helpful because I think a lot of what we're seeing is helpful to categorize it in this way. One of the challenges that we have is what we're implementing is not fully baked yet. So there's evidence behind it, but it's not a specific intervention. So we're using more
It sounds like you and Kelly and Kathy could all get together over happy hour and figure this out. Because it's just plain messy. And maybe just knowing that you've got kindred spirits who are kind of struggling in this in very similar ways, that in and of itself can be helpful. But what you're saying about, the importance of defining what it is really important. And you can use the kind of the natural rollout that's happening, or the natural kind of uptake of these concepts or whatever it is, to explore and define what it is. Because there will always be settings where you want this to be used that are not taking it up. So there is more work that, there's plenty of work to go around, and plenty of work for the grants that we get funded for. I think the trick is, kind of negotiating or building in enough fluidity to be able to structure for the greatest knowledge gain, while at the same time showing that you've got rigor, you know what you're doing, for reviewers who are, scoring your proposals.
TDF, can you talk about, are there any updates, what are we doing with theoretical domains framework and the alignment of CFIR with TDF?
So
Together a lot.
the question is about the TDF, the Theoretical Domains Framework, which is a framework developed by Susan Mickey and colleagues. And the TDF primarily, it also has a whole big collection of factors or constructs, but they're focused more at the individual behavior change level. So what I think about, just so you all know what the TDF is, it may have factors related to the importance of self-monitoring. And the implementation strategies may have the importance of doing audit and providing feedback, which is more at the organizational level. And the CFIR has a construct related to goals and feedback. So what kind of, for teams, what kind of feedback are they receiving, and to what extent is it aligned with organizational goals? Whereas the TDF will talk about doing those similar types of actions, but for me, like with my Fitbit, am I getting my steps in today? So it's about my own change rather than collective change. There are some constructs within the TDF that do speak to collective level constructs, like social pressure, I think, is one, or something along those lines, for example. Environmental factors is another. So the question is, what's happening with TDF? And you said you do use it together with the CFIR. So
We code them together, we combine interview guides.
fantastic.
So instead of taking the individual components of
Yeah.
CFIR, we dump all of them into the TDF and code everything with TDF.
Okay.
And
So you have like a crosswalk between the CFIR and the TDF? Okay. All right. So there is a paper that we published. I think Alexis Kirk is the first author, or maybe it's Sarah Birkin.
Sarah Birkin did, how they relate.
Yeah. So a synthesis of published articles that use both the TDF and the CFIR, and found that the most common reason, I think, is because recognition that people wanted to include the TDF because to get at the individual factors, which the CFIR by design does not really include. We have a few factors, but they're very high level. And then the CFIR because of the organizational collective issues for implementation. I know that Susan Mickey she has an entire center devoted to the behavior change wheel and that whole process for using the TDF. Very similar process to what I identified here about identifying the constructs or the determinants of change, and then identifying strategies or techniques. They call them behavior change techniques and creating kind of multi-component approaches for behavior change. What's happening with that? They're going full steam ahead. I'm not explicitly collaborating with them, but I have a lot of respect for that work. And I think that, this is an example of kind of, alternate lenses being applied. And I think that more and more people are recognizing the value of using them both together because they kind of leverage one another. Is that the way you're using them, or?
So again, we usually plan a priority because I just found in projects when we were doing analysis using TDF, it did not capture, like we'd end up with the bulk of the dialogue sitting in environmental context and resources.
Yeah, okay.
It, right?
You're confirming my,
and so we
okay.
leaned on the CFIR to say,
Yeah.
we're gonna,
the CFIR will basically explode the box related to environmental factors.
and
That's one way
so
to think
insightful.
about it.
I mean,
Yeah.
that move just to push things into CFIR
Yeah.
and to look at the distribution, not even enumerating the strength of where they are, because sometimes we have difficulty actually nabbing, like to what
Right.
extent is it positive or negative, or
Right.
or the degree to which, but it's giving us tons of data around where is the bulk of the dialogue sitting?
Yeah.
Where does it get coded?
Yeah.
When we put it on a frequency analysis, what are the top 10, 12, 15 categories that are providing issues with that intervention?
That are brought up most often across the
different
two
across
frameworks.
sites.
Yeah. Yeah.
So that's been key.
Yeah, so that's great. I'm collaborating with Sarah Birkin on another paper and several others, Per Nielsen, and others, on thinking about intervention. So the combination of these two frameworks, do we intervene at the individual level? Is implementation all about getting physicians to change their behavior? Well, yes. Or is it about changing organizational structures and processes and perceptions? I think the answer is yes. So, there is one kind of cadre of science that is very much about individual change. We can't be successful with implementation unless we get individual clinicians to change what they're doing to accommodate the new practice. And then there are, implementation science tends to focus on the collective level or the organizational level. But really, it needs to be a marriage of both. And we need better, more concrete thinking around what that interface looks like conceptually. Yeah. So we kind of got off into the stratosphere a little bit, but I geek out about that. I enjoyed it. All right, well, yeah. Thank you all for coming. All right. Have a good week.
Thank you all for coming. This was absolutely insightful, super fascinating, really helpful, I think, to most of us. So thank you so much again, Laura.
You're welcome.
Thank you.
Thanks for having me.